I think we're ready.
Okay.
So this is, welcome everyone. It's Ron Rufter from RWR Dental. It's the Monday morning chat, even though it's Friday afternoon, for someone that I'm interviewing. I'm very pleased and honored to have Dr. Johan Aps with us today. Dr. Johan Aps, tell us a little bit about yourself.
I got my training in Belgium at the University of Ghent, and I graduated as a dentist in 1993. Then I continued to study pediatric dentistry. I got that degree in 97. Then I got the opportunity to start a PhD thesis, which I defended in 2002. And then in 2005, I started radiology in London at King's College. And so my professional activities have mainly been University of Ghent, University of Washington in Seattle for 6 years, and University of Western Australia in Perth in Australia. And so now I'm back in Belgium and I'm teaching a little bit in oral hygiene students, and I'm working in private practice here and there. And then most of the time I'm lecturing.
Fantastic. Dr. Aps, I mean, the key thing and how I guess, learned about you was the intraosseous technique. And
that's right.
You've been doing this forever. I know it's a technique that has been around for many, many years, but what can you tell us about intraosseous anesthesia for dentistry?
I got exposed to it in 2005 when I started teaching about local anesthesia at the University of Ghent. And my predecessor only had a syringe. Okay. And I thought if I'm teaching students, I have to be able to teach them all the different techniques that there are available in the world. And so I started exploring different things. And one of the things that came across my path was intraosseous anesthesia. And in the very beginning, I was pretty skeptical about it because you have to drill a hole through the cortical bone and then make sure the needle is deep enough in the spongy bone. And it was kind of exciting in the first place, but sure. But I got pretty well convinced after maybe three weeks that this is really the technique that works in almost every single case. And if I say almost every single case, I mean like 99%.
That is just incredible. Why do you think it's not as well known as it should be? Because I mean, I'm a digital person. I've been digital since the year 2000 with CAD/CAM. I saw this product way back when, and then I finally met them again in 2014. And I asked, what are you guys doing for Canada? And so we organized a contract together, and I've been having some success. But it seems like it's a very, I don't know, people, I guess the dentists are afraid of the technique. Is that possible?
I think yeah, you might be right. They might be a little bit afraid to use the technique. It's probably because they never got it they never got it in their training, in their initial training as a dental student. And I think that's where it all starts. The second thing is it's more a kind of a philosophy when you work with intraosseous anesthesia. It's a different mindset of how local anesthesia should be done. I think for most dentists, the biggest stress is drilling that hole and finding the right spot where you have to inject the anesthetic. But it's all a matter of experience. And if you buy one of those devices because you think, oh, I'm going to use it in case of a failure, then you're not going to be an expert very soon either. And so what I've seen over the years, and I've been teaching about this technique since 2006, all over the world, as you know, because that's how we met. I've seen a lot of dentists that purchase the device and then almost never use it. And we used to organize master classes, and then people would come back and they would explain what happened to them, or if they didn't use the device, why they didn't use the device, or if they had a failure. And then it was up to me to find out why that failure occurred. Right. And most of the time it's because they're not sticking to the guidelines. They're not sticking to the rules. And that's when you start making mistakes. And the only way to make mistakes is when you don't use it often enough. It's like driving a car. If you only drive on Sundays, you will never be a good driver. If you
Right.
drive 7 days a week, there's a higher chance that you will be a pretty good driver. And it's the same thing with the intraosseous technique. If you only use it in cases where you've got a failure or the patient has a irreversible pulpitis and it's very painful and you can't get it numb, and then you take that quick sleeper out of your drawer and then you start the whole procedure, but you haven't done it enough, then yeah, it's not as convincing then. And I've been using it since 2006 as my only device that I use. It doesn't mean that I treat every single case with intraosseous anesthesia.
Right.
I compare the Quicksleeper to a Swiss Army knife because it allows me to do all these different things. Like the other week, I had a 5-year-old that needed an extraction, and he was pretty afraid of everything. And okay, there was no way of performing an intraosseous anesthesia. So I first performed infiltration next to the tooth, and then I performed my intraosseous anesthesia after that, just to make sure that it was well numb and it was okay for him. And it allows you to do all these different things. If you need to do a palatal injection, which is usually pretty painful for most patients, this device is able to do that very, very gentle. But it's in your, if you master the technique and if you master the device itself, then you'll be successful. But when you only take it out of the drawer when you need it, then yeah, it's not going to work as well.
Yeah, no, I totally agree with you, because I remember there was a dealer here way back when for the Quicksleeper 1, the first generation, and it was sold for that. It was sold for whenever nothing else worked, they would pull it out of the drawer, use it, and it would work. But now, I mean, with the 5th generation, it's more like a intraoral camera type thing. It's all automated. We've kind of changed our training behavior, basically because of the help with Dr. Andrew Prin. So what we're doing is one training, which is just anterior and premolar. And the second training is the molar and then rich molar pad. And that's been so much more successful. And the thing is to get rid of the syringes, and that's the best way to apply this product. It's a tool. You guys are dentists. I mean, you should know how to use a tool, which is fine. And I think if we follow it properly, we've seen just game-changing effects on the dental practice. So not just for the doctor, but also for the staff and especially for the patient. So what do you use anesthetic-wise? What product would you suggest? Or
here in Belgium, most dentists will use articaine 4%, 1 in 200,000 epinephrine, because that's for most dental procedures the standard. The downside of using articaine is that it lasts pretty long. It's about like a 3.5–4 hours that it lasts, but it depends on the procedure that you've done. Right. If it was a restorative procedure, which doesn't really need to be anesthetized for the next 3 or 4 hours, then you can easily use lidocaine 2% with 1 in 80,000 epinephrine, which is what most dentists will probably use. But in case of a extraction, for instance, you want the patient to walk home with no pain.
Sure.
And you want them to be at home for a couple of hours more without any pain as well. So then articaine is probably a better product. But I know in the US, articaine is not the favorite anesthetic of a lot of dentists. I never understood why, but I know that in the US they use a lot of bupivacaine. I'm not sure about Canada, if they are more leaning towards the European anesthesiology rules or more towards the American, but that's what I remember when I was working in Seattle. There was no way especially not for the mandible, really? No way you would be using articaine. But it all depends on the indication and the treatment. And in some cases you can use mepivacaine as well, because mepivacaine is the only amide anesthetic that doesn't cause any vasodilation. All the other ones cause vasodilation. Okay. So if you use let's say lidocaine without vasoconstrictor, then it actually causes vasodilation, which means if you inject into the bone, it disappears immediately into the bloodstream, which is quite uncomfortable because you can't work, because before you even performed your injection, the anesthetic is already gone, so it would be useless.
That is very informative. Thank you so much. Last question basically is to, obviously with all your knowledge and all your world travels, the best way or any little tips or tricks for some dentist that is just starting out. I mean, what would you suggest maybe to help them out?
Well, I think the best way to start out is to first make make sure your syringes are out of the way.
Okay.
And the first patient that comes in that needs an infiltration anesthesia, just use the Quicksleeper for the anesthesia, for the infiltration.
Awesome.
The next one comes in, try another one, etc. Try step by step. And if you're not really very comfortable using it for a lower molar or upper molar, for upper molars, I would suggest just perform infiltration as you would do with a normal syringe, but get used to the device, get used to the pedal, get used to the handpiece. And for the mandible, of course, where infiltration is not very successful, you can, if you've got a good radiograph and you see that there's more space between two teeth, it might be 2 teeth away from the one that you want to treat, especially if that space is distal from that tooth that you want to treat. Go for that spot, because it will be easier for you to get the needle in the right spot in the bone, and don't be afraid to perforate the bone deep enough, because if you don't perforate deep enough, you'll get interdental papilla necrosis, which is exactly what you don't want.
Okay.
And so a lot of cases I've seen where people had that kind of side effect of the anesthesia is because they were afraid to go too deep, or deep enough, not too deep, but deep enough into the spongy bone.
Right. And
then they used a very high concentration of vasoconstrictor, which makes it even worse. But yeah, and also positioning around the patient is very important.
Sure.
And I think the best way to practice would be start with easy cases first, and then build up step by step. And that for me, that was the only way to shorten the learning curve.
Absolutely.
It's, just start with easy cases first, and then gradually make it a little bit more difficult on yourself. And before you know, you're just doing the retromolar pad all the time for the mandible. Yeah, which in my opinion is the easiest one there is. Yeah.
And that would be replacing the block in your opinion?
Completely.
Okay.
Yeah.
Absolutely.
The only thing that people should remember is when they do intraosseous anesthesia is that the only thing that's anesthetized is the pulp of the tooth, the periodontal ligament, and the attached gingiva. So if you're performing surgery, then the rest of the mucosa is not anesthetized. So be very careful. Don't take your scalpel and start cutting, because you'll hurt the patient.
So it's everything.
I've done extraction. Yeah, I've done extractions with Quicksleeper a lot. And it's actually what I've been doing for the past 6 months now. Only extractions, no restorative treatments, the practices I work for. But in the very beginning, I think it was 2006, maybe 2007, good friend of mine needed a tooth to be extracted, and I think it was 3-7, and everything had gone really well. I extracted the tooth, and I decided I need to suture this, because he's my friend, and I really want to make sure it's really well done. So I started suturing, and he almost jumped against the ceiling, just because I was so stupid. I completely forgot that the rest of the mucosa and the gingiva was not anesthetized. So I had to anesthetize the soft tissues a little bit. But if you realize that it's just a pulp, the periodontal ligament in the attached gingiva, you're good to go.
Just the attached. Awesome. Again, Dr. Aps, thank you so much for this time. I know you're a very, very busy man, and I look forward to maybe chatting in the future. Thank you so much for sharing your information and your knowledge.
I look forward to seeing you again. All right.
Thanks, Dr. Aps. Have a good weekend.
Bye-bye. Bye.
Bye-bye.